Bleeding esophageal varices. Esophageal varices are dilated tortuous veins usually found in the submucosa of the lower esophagus. However, they may develop higher in the esophagus or extend into the stomach. Pathophysiology and etiology. Nearly always because of portal hypertension, which may result from obstruction of the portal venous circulation and cirrhosis of the liver. Because of increased obstruction of the portal vein, venous blood from the intestinal tract and spleen seeks an outlet through collateral circulation, which creates new pathways of return to the right atrium and causes an increased strain on the vessels in the submucous layer of the lower esophagus and upper part of the stomach. These collateral vessels are tortuous and fragile and bleed easily. Other causes of varices are abnormalities of the circulation in the splenic vein or superior vena cava and hepatic venothrombosis. Mortality rate is high because of further deterioration of liver function to hepatic coma and complications such as aspiration pneumonia, sepsis, and renal failure. Clinical manifestations: hematemesis, vomiting of bright red blood; melena, passage of black tarry stools; bright red rectal bleeding from hypermotility of the bowel or rectal varices. Blood loss may be sudden and massive, causing shock. Diagnostic evaluation: upper GI endoscopy to identify the cause and site of bleeding. Serum liver function test including ammonia level, it will be elevated. Management: emergency treatment, restoration of circulation, blood volume with blood and IV fluids. Vasopressin, pitracin IV may be used to reduce portal pressure by decreasing splenic blood flow and to increase clotting and hematemesis, although its efficacy is not proven. Splenic blood flow, SPLANCHNIC, splenic blood flow. Complications include hypertension, bradycardia, esophageal ulceration or perforation, aspiration pneumonitis, worsening varicose hemorrhage, water intoxication, cardiac ischemia in patients with pre-existing cardiac disease. Third one, gastric lavage to remove blood from the GI tract and to enhance visualization for endoscopic examination. Fourth, esophageal balloon tamponade, whereby balloons are inflated in the distal esophagus and the proximal stomach to collapse the varices and induce hemostasis. Complications include esophageal necrosis, perforation, aspiration, asphyxiation and stricture. This procedure should be reserved for patients who are known without a doubt to be bleeding from esophageal varices and in whom all forms of conservative therapy have failed. Endoscopic sclerotherapy. Fifth point, a sclerosing agent is injected directly into the varices with a flexible fiber optic endoscope to promote thrombosis and sclerosis of the bleeding sites. To control bleeding and reduce the frequency of subsequent variceal hemorrhages, but repeated treatments may be required. Complications include esophageal ulceration, stricture and perforation, endoscopic esophageal ligation. Variceal banding may be urgent or non-urgent. Second part of treatment, non-urgent treatment. Under this, administration of parenteral feedings to allow the esophagus to rest. Surgical ligation of varices to tie of blood vessels at the site of bleeding. Esophageal transection and devascularization that separate bleeding site from portal system. Surgical interventions to lower portal pressure by shunting blood around the liver. Care is similar to abdominal surgery, complicated by severe cirrhotic liver. Portal systemic, that is portocaval shunt. Portal vein is anastomosed to the inferior vena cava to reduce variceal blood flow and pressure. Splenorenal shunt. A shunt is made between the splenic vein and the left renal vein after splenectomy. This is done when the portal vein cannot be used because of thrombosis or for other reasons. Interposition mesocaval shunt. Superior mesenteric vein is grafted to the inferior vena cava. Last one, transjugular intrahepatic port systemic shunting, TIPS. Tips: a non-surgical approach. Transjugular intrahepatic port systemic shunting. Complications: exsanguination or recurrent hemorrhage, portal systemic encephalopathy. Nursing assessment include monitoring vital signs and respiratory function, assess level of consciousness and impending signs of liver failure. And nursing interventions must include maintaining adequate tissue perfusion, preventing aspiration, reducing anxiety and fear, and patient education and health maintenance. Regarding signs and symptoms of recurrent bleeding, and avoid behaviors that increase portal system pressure like straining, gagging, Valsalva maneuver like that. And then encourage him to take high protein diet and encourage the patient abstain from alcohol consumption. Thank you.